testosterone. And testosterone not only controls our sexual characteristics, but also contributes to bone health, for example, protects our heart as well. So to be told that you have a cancer that is driven by testosterone, and actually a lot of treatments for prostate cancer is hormonal, meaning that you're trying to block testosterone, can have a significant impact on our daily functioning. Okay, and that can come as a bit of a shock if we're fit and well and cycling and riding and running, and all of a sudden we're going to be faced with a lack of testosterone. And one of the biggest side effects of a lack of testosterone is tiredness and fatigue. So some of you know I water ski. My water skiing partner had prostate cancer. He still water skis, but he's on hormone treatment for his prostate cancer. And even though he's very fit, he's older than me, but much fitter than I am, he still gets tired on the wake. And so this is not to belittle the fact that actually it's all a bed of roses out there and you're going to have treatment and you're going to be fine. It does come at a price. And the price for getting that cure at 15 years can affect the way we function sexually, can affect our waterworks, our urine function, can affect our bowel function as well, and our overall sense of well-being. The more advanced your prostate cancer, or the longer you leave it, the more likely you're going to need to receive some form of hormonal treatment. And that hormonal treatment, as I say, can affect your quality of life for quite a considerable amount of time. And so again, that's another reason for trying to pick things up early and detect things early. Now, again, you wouldn't come to me for me to diagnose your prostate cancer. That would be done with a urologist. Okay, a urologist is a surgeon who will do a biopsy of your prostate. But as all of you who have been through prostate or know people who have had prostate, the dreaded thing about going to the GP is the thought of having your bottom examined. Okay, not a pleasant thought or thing to have done, but actually an important part of the whole workup for prostate. So it's not something that is as simple as having a blood test, but actually it is important to contribute to our sense of well-being and to further the investigations. So, Steve, I don't know how we're doing for time, but I was going to spend another few moments talking about prostate cancer and perhaps taking specific questions.
Sounds good, yeah.
And then perhaps I'll talk to you a little bit about what I'm doing at St Martin's and my call to priestly ministry and how I manage that with my secular work. Just coming back to treatment for prostate cancer. In the past, we've always thought that if you had cancer in the prostate, we needed to treat the whole prostate. Now that has changed over the last 3 or 4 years. And nowadays we have treatment pioneered in places like Guildford and London, where I work at Imperial, where you can use something called focal therapy. And focal therapy just targets where the cancer is, rather than treating the whole prostate. And the advantage to that is that there are less side effects. So just like brachytherapy in the day was better than surgery or radiotherapy in terms of side effects, focal treatment is the new thing. And I'm a radiation oncologist, so most people come to me for external beam radiotherapy, which is slightly different to the internal radiotherapy Chris and Jonathan had. And that focal treatment is actually one session. Okay? Not for everyone, it's a specific indication, but actually you can have your prostate cancer dealt with within a matter of 2 or 3 weeks from diagnosis. Okay. Again, another reason to go early to your GP and get checked out, and not waiting necessarily until you get symptoms. Generally speaking, most GPs would offer a PSA blood test to anyone over the age of 50, or anyone who has urinary symptoms, even if they're under the age of 50, but with a family history of prostate cancer. So something just to chat to your GP about. Most GPs in this area, most GPs in London, do not have a problem doing what I call a well-man check. Paul?
Steve, I don't think that's quite true, actually. My experience is that quite a number of GPs are not in favour of doing PSA tests, and basically you've virtually got to twist their arm for them to do it. I, for example, I have a blood test every couple of years,
Yeah.
just a routine blood test, and a PSA is not included in that unless you specifically insist on them included.
So the guidelines are a little bit more woollier for repeated PSA samples. So the idea is that part of a well-man check at the age of 50 should include a PSA. And thereafter, it depends really on symptoms or whether that PSA was high or low to start with. But generally speaking, the advice to GPs is for at least a PSA blood test every 2 to 3 years, if not annually, generally speaking.
Steve, we've probably cleared up most of the questions I was going to say about getting PSA tests. Obviously, I've got to go to the doctor if I want to get one. I rather thought that they would approach me and say, well, you want to have one, so often, but clearly not. What I was going to ask though is, you've mentioned symptoms, but without specifically specifying what the symptoms are.
There's a reason for that, and that's because the majority of prostate cancer do not present with symptoms. The majority of prostate cancer do not present with symptoms. The commonest symptoms that one might get with prostate cancer is actually blood in the semen. That's probably the commonest if we go asking patients in detail. Or blood in the urine, though that's less common. The other urinary tract symptoms, such as going to the toilet more frequently, or stinging or burning when you pass your urine, or getting up more frequently at night, they can be associated with prostate cancer, but generally they're more attributable to just a benign swelling of the prostate gland, which can coexist with prostate cancer. And that is why I deliberately haven't mentioned the symptoms, because my view is that you shouldn't really be waiting for symptoms, that you should have a screening test, or if you are concerned about family history or you haven't had a PSA blood test, then that should be the way forward. But urinary symptoms, and that is why generally speaking, if you go to your GP and the PSA blood test is high, most GPs will do a urine test first of all to exclude any infection.
Okay. Sort of following on from that, then, in terms of symptoms, I know you don't want to...
No, I'm happy to talk about symptoms,
One of the other sort of big no-nos to talk about amongst men is erectile dysfunction.
Yes.
Now, since testosterone levels, high levels of testosterone, or normal, should we say, levels of testosterone, benefit from what you're saying, the development of prostate cancer. If you suffer from ED, then presumably your testosterone levels are lower. And that's more likely to happen during older age, isn't it not?
So that's a very good question. So there's various tenets to that. I mean, the first thing to say is that erectile dysfunction is different from sexual arousal, which is libido. So the testosterone hormonal level increases your desire for sex, your libido. The actual mechanics of getting an erection is all to do with blood flow. So for example, if you're a smoker, if you're diabetic, if you've got blood pressure, all of those change the circumference or the diameter of your blood vessels, and the nerves as well. It affects the nerves, and it's the neurovascular bundles next to the prostate that control the erections. So drugs, for example, like Viagra, work by dilating up the blood vessels. That's how one gets an erection. So you're right, the testosterone level does fall slightly as one gets older, but the majority of erectile dysfunction in this country is caused by other medical problems, not necessarily by prostate cancer. And NICE, which is our clinical governing body, have issued GPs with a whole list of red flag symptoms, and erectile dysfunction is not one of them as a marker for prostate cancer.
I've got two questions. One is just a quick one. The focal treatment you're talking about, is that the green light? What we know is the green
No,
light?
so that's the green light is a laser treatment for the benign prostate swelling. So I'm talking about cryotherapy or HIFU, high intensity focused ultrasound.
Right, okay. And the second thing is, can we rely on the PSA test? So if you have a PSA test giving you the all clear, can one rely on that, and how long can one rely on it for?
So that's a very good question. So 10% of my patients will have prostate cancer but a normal PSA. So about 5 to 10% don't make PSA. And that's because you can have different types of cancer in the prostate. Okay? That's very rare. Generally speaking, there's 30,000 cases diagnosed a year of prostate cancer in this country. That occupies a very small proportion. I see quite a high proportion of it because I'm in a specialist centre. But generally speaking, yes is the answer to that. And that is why you have to combine the PSA blood test with a rectal examination. So the two together increases your sensitivity of diagnosing prostate cancer. Now, generally speaking, PSA was introduced into clinical practice in the 1980s. In the last 5 years, you can actually now diagnose prostate cancer on a urine sample. Okay, it's not come into mainstream practice yet, but there's all sorts of ways of diagnosing prostate cancer without the need for a blood test. But I would say is that the digital rectal examination, the PR examination, and a raised PSA warrant further investigation to a urologist.
Okay.
So the caveat to that is if your PSA is normal, but you're getting blood, for example, in your semen, what we call hematospermia, that is an indication for a urology referral, and the GPs know about that. Sorry.
And just following up on, I think, what Chris's second point was, how long can you rely on having a negative PSA test and a negative PR?
So, as I say, the advice that goes out to the GPs, and obviously the GPs will decide that on an individual basis, but our recommendation is probably repeated every 2 years.
Are the GPs managing to do PRs online now?
That's a good question. It's quite
probably like
interesting.
to.
Well, it's quite interesting because when I was training at medical school, I probably only did about 6 PR examinations. And then, of course, that's it. You wouldn't do any more until you specialise. I didn't do any PR examinations until I started doing oncology. So I would say that a GP's PR examination is quite limited. and it's really there for a gross estimate. Joking aside, no, of course they can't do a PR online. But if your PSA is 10 or 15 and the normal range roughly should be about 5, then usually what the GPs do, and especially with lockdown and what we've gone through the last 2 years, is do a direct referral to the urologist. Because even if the PR is normal, you're still going to end up going to your urologist for a biopsy. Chris, sorry. Yeah.
Just one thing I'd like to say about our national health system, as marvellous as it is, we can't rely on our GPs to be proactive about our individual health. We need to do that, each one as an individual. And personally, since the age of 40, I've insisted on going to see my GP, and I've tried to keep the same GP so there's an element of continuity. The system doesn't lend itself to do that normally, but try and see the same person each and every time, and in that way, just get yourself checked out on a regular basis, and I would suggest more than every 2 years actually.
Yeah. So for example, I help out Bupa a lot and PPP. They will offer their subscribers to a well-man check, an MOT, which starts at the age of 50, and I think you can repeat it. But that's one way of utilising that.
In this area, there does seem to be a degree of mixed messages. So on the one hand, like local GP practice, you would have cards saying, get your prostate checked out. And a few years before that, it was testicular cancer, etc., etc. But my experience recently has been that you have to fight pretty hard for a PSA. And in addition to that, I was shown a card from cancer research with lots of little people, symbols on it, indicating to me why I should not have or should not be given a PSA too frequently. And too frequently in my case was every 2 years.
So if we compare what happens in this country with what happens in the States, for example, everyone gets a PSA every year after the age of 50. And a few years ago, there was some research done on looking at the outcomes of regular surveillance PSA against waiting until there were symptoms or waiting until there was a problem. And actually what they found was, you see, the problem is if you have a raised PSA, ultimately you're going to have a biopsy to either exclude prostate cancer or diagnose it. There's no way about it. You can't just leave it. And what we were finding was that if we just routinely gave everyone a PSA blood test, 40% of people may have a minimally raised PSA, but you'd have to put all those people through a biopsy. And for those of you who have been diagnosed with prostate cancer, you'll probably recollect it's probably not the most pleasant procedure. Okay, and remember, we're taking previously fit and well men, and all of a sudden they're going for a biopsy, worried that they have cancer, and the UK thought that actually that placed a lot of stress on individuals, and charities like Prostate Cancer UK were being inundated by well people worried that they've got cancer. And then of course what happened was we did the biopsy and we couldn't find cancer. And so what were we to say to the patients? They didn't have cancer, or could it be that we missed the cancer because we didn't sample the prostate well enough? So that was the case about 5 years ago. Nowadays, in the hospital, we've got such fantastic scans, MRI scans, that actually we can make a diagnosis of prostate cancer even before the biopsy. we can see changes on the MRI scan which we couldn't see a few years ago. And so that has been a bit of a paradigm shift recently. So maybe not all GPs know about that, but the point being is that we've sort of gone back to, if you have a high PSA, you should be referred in, because it doesn't necessarily mean that you'll end up having a biopsy. What it will mean is that you'll have a scan, which will be an MRI scan, and providing you don't have a pacemaker, most people should be able to tolerate an MRI scan, and it's non-invasive. And that can act as a reassurance. So you don't need a biopsy. So that information is slowly changing. So we're sort of back to get your PSA done regularly after the age of 50.
I just want to, I've moved into Horsley's in the last 3 years and I've taken interest. And I'm conscious that I have had a PSA test once here, but it only happened because I insisted, rather like Chris said. I said, I haven't had a test for 7 years, and it was suggested to me that I ought to have it done every 5 years, and I therefore really would like you to do it, and so they did, and they did other tests. But I think that the point that Chris made is that unless we stand up and fight for our health and recognise that sometimes, I feel I'm fit and healthy.
Yeah.
I think I am reasonably able to do most things, but equally I also recognise that the only way that I'm going to have the checks that I need doing is if I stand there and say, I would like these done. I am not this bio man that I would like to think I am. I'm a normal human being.
Yeah. Just as a show of hands, for those who are over the age of 50, I mean, how many of you have routine blood tests at your GP anyway? So it's about more than 50%. So it shouldn't be a problem for the GP to add on a PSA blood test without any inconvenience. I appreciate there may be discrepancies and variations throughout the region, but sorry, Reynolds.
Steve, when I shared with you some time ago that my mother died of breast cancer, your response was to say you should have a PSA test. Could you say a little bit about that link?
Yeah, so we've been coming to understand that just as there is a racial element to prostate cancer in that Afro-Caribbean men are more at risk, there's also a genetic risk for prostate cancer. And what we mean by genetic risk is you harbour certain genes that, when mutated or changes, causes the development of cancers. And the two commonest genes studied in the UK for any cancer is the BRCA1 and the BRCA2 genes, BRCA1 and 2, which have usually been confined to women because that's the gene that's been implicated in breast and ovarian cancer. But interestingly, men also have that mutation. 5% of patients with prostate cancer under the age of 50 will harbour that BRCA1 or BRCA2 mutation, and that puts them at risk of developing prostate cancers. If you know you've got a history of breast cancer or ovarian cancer in your family, again, that should be impetus to getting your blood test checked. Now, that may not be common knowledge with GPs, should be getting out to them, but exactly as already been said this evening, it should be sort of driven by us if we know that. It's not common knowledge, but there's a lot of it about now in the medical literature.
Right, just going back to the PSA again, I've a number of friends who've died from prostate cancer and a number who've had it and recovered from it. In every single case, they had either a very high PSA or an increasing PSA. Rapidly increasing PSA.
Yeah. So that brings back to what I was saying right at the beginning, is that actually where we're at the moment is trying to detect that asymptomatic rise in the PSA, i.e. the PSA goes up before you get any symptoms and you're still well. And that's where we need to intervene. Waited until the PSA starts to rise or goes up, puts us into that category of those 1 in 5 men where the cancer is likely to have already spread outside the prostate. And that's where we see that huge difference in survival, even with treatment.
And just going back to your statistics at the beginning, a friend of mine who was in his late 80s just died, not from prostate cancer, but he was told by a surgeon that he wasn't going to die from prostate cancer.
Yeah.
But most men will die with it at that advanced stage.
Yeah. So that is absolutely right, and that's what I said right at the beginning. Is it, prostate cancer is one of these weird sort of cancers. It's not just one cancer; it's a heterogeneous group of diseases. And the reason we do the biopsy is because it can tell us about the grade of the cancer, and it's the grade of the cancer that tells us whether you need treatment for it or not. So what we call a low-grade cancer, there's a scoring system called the Gleason score that tells us about the grade of the cancer. If the grade is low, chances are we don't need to do anything about your prostate. Something else will catch up with you. And this is the conundrum, isn't it? That here I am spouting about how you should get yourself checked and this treatment. But actually the other side of it is, do we actually need to treat you? Can we be bold enough to wait? Because actually the downside of having treatment is the side effect profile, and actually we may be over-treating prostate cancer. So certainly in my practice, I insist for 99.9% of my patients that they have a biopsy, even though it looks fairly obvious. I still want a biopsy.
When you talk about a rapidly increasing PSA, what do you actually mean by that? And if you're only having PSA for 2 years, would you spot a rapid rise?
So that is a very good question. So for patients who have prostate cancer, a rapidly rising PSA is one that doubles in less than 6 months. So it follows a logarithmic scale, so it's not actually going from 2 to 4 in 6 months that defines a rapidly progressive cancer. But that's in the context of having a diagnosis. It normally takes, if we look at mouse models and we sample their prostates, the changes from a normal prostate to a cancerous prostate can take up to 9 years. So it is likely, even though we pick up the cancer early, it would have been present probably if we went looking hard enough a few years before. But you're right, there are no specific guidelines for the GP. You can imagine 30,000 cases a year, how that would create quite a lot of burden for the GPs.
Thank you, friends. Any more questions, please? Steve, if there are questions, we'll see you afterwards.
Come and,
Steve, that's been brilliant. Would you just say a little bit about your call to the priesthood and how your faith has helped you?
Yeah. So I feel that I'm in a very privileged position because up until about 10 years ago, medicine was what I thought was my vocation. And one of the things about my job is that I'm very privileged. I get to see patients who are very vulnerable. They come for first time, as I said, usually quite a lot of men are fit and well, never been to the doctor. Now all of a sudden they've got cancer, and it's something that they can't control. I've had rowers, I've had people, in the national football team who have come up and said, I cannot believe this. Why have I got what I've got? And if there is a God there, why is he causing this upon me? It's those sorts of open questions that patients start to ask themselves when they lose control of their lives, and all of a sudden their lives are just chaotic and nothing really makes sense to them anymore, because it's something that no matter what they do, they can throw money at it, they can do whatever they want. It's not going to change the fact that they've got prostate cancer. And that does open up a discussion about, one, spirituality. It opens up a discussion about feeling of despair and loneliness. Well, probably not despair and loneliness. Isolation, I think, is the word I'm looking for. Whereas all of a sudden, we have something that actually they need to trust me or the healthcare professionals in terms of what they're going to do about it. And I suppose it was that realization, not only about that specific circumstance that I was faced in, but also a recognition that actually it's not just about the prostate cancer with patients. You know, people ask me, Steve, do you treat prostate cancer? Yes, I treat prostate cancer, but more importantly, I treat patients with prostate cancer. And it's the patient's bit, it's the person, whereby sometimes I think we fall down as medical healthcare professionals. We focus on the cancer or the science, but we leave behind the patient. And I think for me, there was a recognition that delivering holistic care and healing wasn't necessarily about giving the best cancer treatment. I think, as I was saying, I've forgotten your name again, I'm sorry, right at the back. Ollie, you know, some people don't want to have their cancer treated. You might think that you have their best interests at heart, but it may not be what they want. And on the counter side to that is that I feel my spirituality, my vocation to ordain ministry has really helped me open up and be able to have a conversation not only about treating the prostate cancer, but more about seeing the patient as a whole and understanding about what it is to be a human being that is loved by God. And that was the impetus for my vocation to ordain ministry rather than a lay minister. So I still feel very privileged, and actually what I would say is that the pastoral work that I do with Renos has really impacted on what I do as a doctor. So I would say that my priestly ministry and my medicine are synergistic, that actually they're greater than the sum of the two parts. And I'm very proud to be in this position, and I hope very much, and I don't wear a dog collar when I'm in my clinic, but I hope very much people can see that how I act and behave, that I am a Christian. And that speaks to people of no faith or people of faith of different denominations.
That's fantastic, Steve. Thank you for. Do you have any difficulty in your medical field with the line you're taking, the scientific field? Have you encountered any difficulty?
No. And the reason for that is when I first explored my call into ordained ministry, I reflected on a very famous quote by Teresa of Avila about Christ has no hands but your hands, and actually there's an empowerment for us, for me, to actually get on with that process of healing in whatever way I can, and that I am doing God's work in my medical ministry, and I don't see that competing with my Christianity. And in fact there's lots of scriptural reference to healing and actually Jesus empowering us to actually take care of our health in the Bible.
Steve, that's excellent. Friends, any other questions for Steve?
A general one. You obviously are very Christian in your belief. And do you find any difficulty with that team around you? Them understanding how important Christianity is to you?
So we have clear guidelines at work and from the GMC about what we can say and what we can't say. So you're not going to find when you come to me with your prostate cancer that I'm talking about Jesus, okay, because that's not what people are coming to see me for, and so we have to be very clear about that. But all I would say is my door is always open, and patients know that. Patients know, I'd like to think patients know that I'm a Christian by my actions. I don't necessarily have to get involved in a very overt way. Have I prayed with patients before? Yes. Have I prayed at the bedside? Yes. Have I prayed with patients' families who have asked me for prayer? Yes. Has the church helped with my medicine? Yes. I'll give you a very concrete example. So lots of my patients attend the hospital for radiotherapy treatment, and radiotherapy is a course of treatment over 6 weeks generally. And local churches have been very helpful in bringing patients to the hospital. It's a very practical way of pastoral care and ministry, and you know, that for example, that came out of a conversation I had with a patient asking them about their church life. So there are practical measures that can be done that we as a church and of other faith denominations can get involved with the ancillary bit to develop in what I call holistic care. I think it's very important.
Friends, anything else? Steve, that's absolutely excellent. Thank you so much. Steve's, as you can probably figure out, a very, very humble person. He's in his field of oncology one of the top 5 in the UK, and we're so blessed to have him living near us and worshipping at St Martin's. Steve, thank you so much. It's been incredibly helpful on so many levels in so many ways. Would you please accept this as a token of our gratitude? And thank you again so much.
Thank you very much. Thank you.